the first of a series of web seminars on the ethics in clinical medicine. We are using this seminar as a joint effort of the Southern Medical Association and the Southern Medical Journal. The series will begin today with Dr. Anna Poe, who is professor of otolaryngology, head and neck surgery at the Louisiana State University Health Science Center in New Orleans. She is also the residency program director in otolaryngology, head and neck surgery, and is a surgical oncologist. Dr. Poe has spoken a great deal around the United States on the disaster that occurred with and after Hurricane Katrina. One of the main articles in the January 2013 issue of Southern Medical Journal is the special issue on disaster medicine and physician preparedness is by Dr. Poe. Dr. Poe contributed this key article looking at the ethical and legal challenges in disaster medicine. It posed the question to us and physician colleagues the following: are you ready? Now, Dr. Poe, the scenario that you presented for consideration seemed to have been similar to the one that you personally experienced during Hurricane Katrina. So my first question to you is this: what was it about Hurricane Katrina and that disaster that caused so many patient care issues, both medical, ethical, legal, to be scrutinized so closely?
Well, Dr. Holt, as you know, Katrina was an unprecedented event, and it was considered the worst disaster on American soil in recent times. It became very obvious very early on that everyone was grossly unprepared. I think the reason that everything is so highly scrutinized is because patients died and families on the danger. You know, shortly after the hospital that flooded, lost all generator power, and they really weren't functioning as a hospital any longer, was as a shelter. Conditions became very favorable. And rescue was very, very late in coming. The more people were waiting for rescue, they did die. And there was all types of blame shifting at the corporate level and every level of government. And I think the public wanted to know why these things happen.
And you have taught and you have spoken with state and national medical societies about some of the lessons learned. What are some of the major lessons that the medical profession needs to recall and you actually have talked about as an outcome of Katrina's disaster?
Well, there are so many lessons that can be learned, but I think first and foremost is that civilian physicians need to be trained in disaster medicine. And that is the thing that was realized immediately. The other issues really have to do with hospital preparation. We had very little communication, no water, and very little security. Those things are absolutely necessary if you're going to be able to communicate with outside people to get help and rescue for your patient and in order to treat patients safely. Without those, you really can't function as a hospital or as a healthcare provider. The other thing that we learned is that the hospital should not be used as shelters, because when you do that, you're responsible not only for your patients, but for everybody that you take into the hospital, and that can really complicate matters a lot. One of the other things that we learned is that when there is enough warning, the hospital should be evacuated of all patients, if not everyone, particularly babies in the nursery and those in the intensive care unit. That is possible and feasible. My colleagues at UTMB did it twice in the past very successfully, and many of the hospitals from Hurricane Sandy also evacuated. So those are some of the most important lessons that we learned, although there are very many other ones.
We saw pictures, I think, recently of Hurricane Sandy, and one of the major medical centers in New York having to evacuate their little pediatric patients. I think that really struck not only the public but physicians about the impact to their patients, particularly patients, small patients, intensive care patients, and so forth. And do you think hospitals are becoming more prepared since Hurricane Katrina for this?
I do. I think that some of them are more prepared, and I think that other people still feel that it'll never happen to them. But since Hurricane Katrina, there has been concern about it. The nurse that was in charge of the disaster plan in Joplin, Missouri, for example, they had so many drills that they were able to evacuate all patients within 90 minutes following when the tornado made landfall, which I think was just unbelievable. And most of our colleagues in New York also realized that they needed to evacuate the hospital before the hurricane made landfall. Some did not, but most did. So I think the more that we see these disasters, I think immediately following Hurricane Katrina, everyone thought it was the flu. So I think with all the tornadoes in the Midwest last year and then with Hurricane Sandy, I think healthcare providers, hospitals, and the public themselves realized that they may find themselves in the middle of a disaster.
One of the other articles in the special issue of Southern Medical Journal next month is by Dr. Frank Shaggets, who's another head and neck surgeon, and he wrote of his experiences in the Joplin tornado. And as I understand it, out of two major hospitals there, one of the hospitals was not operable. It was heavily damaged. And so they had to concentrate surgery and acute care in the other hospital. So there's this notion of surge capacity. And I wonder if you had any notions about hospitals preparing for this potential surge of injuries.
I think that that's something actually that can be very difficult to do. We know just from the pandemic flu protocol that we may not have enough resources to care for every patient. I don't know realistically and practically how that can be done. I think we have to do the best that we can do. But I think the most important thing is when disaster does strike, that you use all of your resources and you have to really think out of the box and you have to be prepared to construct almost like MASH units, the way that we did in Louisiana following Hurricane Katrina, to take care of the patient. So you just have to constantly reinvent your disaster plan. And that's one thing that we do know. No matter how well we prepare, we may not have thought of every possible scenario. And the plan has to be very dynamic. You have to change it as things happen, as resources become more available, as supplies become more available. So just think that you plan the best you can, but you just really have to be prepared to be very ingenious when it comes to caring for patients.
How have the hospitals here in New Orleans recovered from Katrina? Are all of them operating again, or are some closed? What is the outfall of that for the hospitals?
Well, following Hurricane Katrina, there were 6 hospitals in Orleans Parish that were flooded and were closed initially, which was most of the hospitals. And so there was a really terrible problem with access to patient care. Right now, Charity Hospital in New Orleans remains closed, and there's no plan to reopen it. However, we are building a new state-of-the-art medical center, which is under construction right now. And Lindsay Boggs Hospital also did not reopen and will not reopen due to damage. The other hospitals have recovered fairly well. The medical community is constantly rebuilding and improving. Some of the beds in the hospitals may not be used to the capacity, but you have to understand when the medical infrastructure was almost essentially wiped out by the flooding, that it takes a long time to recover. And I think in 7 years, we have done an incredible thing getting the medical community up and running.
Essentially all physicians now take a residency training in some specialty of medicine. And just thinking about the difficulty of hitting here in New Orleans, that hurricane disrupted not only to medical schools, but residency programs in all of the areas. Was it a difficult problem recovering for the residency programs overall here?
Well, you can imagine we lost our teaching hospitals. So every hospital in the medical center was closed in addition to the community hospitals where the medical students had been trained. So again, you have to really think out of the box and be creative in order to continue graduate medical education. And what our department did and some of our colleagues that we moved upriver to Baton Rouge where there was no flooding, and we established new partnerships there where we could offer training for our residents and medical students in hospitals where we were not formally affiliated with. So again, it's taken a lot of blood, sweat, and tears over the last 7 years for the medical schools and the residency programs to recover. But again, I think we have done an incredible job in doing that because our medical students are still well respected around the country and our residents are very good position.
We had to do that so quickly and reestablish the education and the patient care and the training programs, and you did it within weeks of the incident. So I think you serve now as a model for other training programs in medical schools should they counter such a problem. One of the big issues that we'd like to look at in this interview is the area of ethical considerations. Before Hurricane Katrina, there really weren't the challenges that pressed physicians ethically in the care of their patients. But with Hurricane Katrina, there were so many things that came up that now need to be addressed or were addressed. You've been a proponent for addressing those issues. What are some of those ethical issues that you have felt are important to take care of?
Well, first of all, I think one of the important ethical issues is duty to care. Not every physician may feel the need to be present during disaster, and actually I think it may be unrealistic to assume that everyone is going to sacrifice their lives for the cause of their patients. We all know what the AMA says, but we do have the duty to care during times of disaster, even if it's increased risk around safety. But they modified their physician statement in 2004 to say that the individual physician should look at the benefit to the immediate individual patient and balance that with the need to take care of future patients. And that's because AMA realizes that the workforce, is not unlimited and that. When a survey was conducted, Johns Hopkins Hospital, they surveyed 3,500 people, all healthcare workers, 1,000 of which were physicians. 79% said that they would work on disaster. And then 90% said that they would work only if absolutely necessary, if specialty was needed. But when they probe further, 26% of all healthcare providers said they would not come to the hospital no matter what. So I think the ethical question there is, how much is the physician expected to sacrifice for the patient? And if they do balance immediate care to one patient to provide future care, how would they feel about themselves, or how would they be viewed if they do lose patients untreated for their own safety? The other big ethical issue, I think the ones that are the most difficult and most pressing, is following the NASH casualty, disaster triage protocol. It basically goes against everything that's on the medical school and residency. We're taught to give care to everybody who presents to us, especially the critically ill. But we know with the disaster triage protocols that we're to do the most good for the most number of people to save as many lives as possible, knowing that there will be some patients that we cannot treat or some patients that can't be evaluated according to the protocol. This is really difficult for a civilian physician to embrace, and many say that if they had to, they're in that situation that couldn't follow the protocol. So I think that is really one of the most difficult things because we're just not used to doing that, and I don't think the public really understands well, what happens during a mass casualty event, and that not everyone will receive treatment.
Sure. Well, one of the good things that may have come out of the recent conflicts in the Middle East that have required large numbers of our military physicians to participate in combat casualty care is that they're quite aware of the triage protocols. And so when they teach at our national meetings, when they join the community after military service, they're really a great resource to help us in educating our fellow colleagues about that aspect.
Absolutely. It was really similar. I mean, I've never been to war, but from everything I've heard and read, it was really similar to like a war-like situation. And I think that's what's difficult for Americans to realize, that we were not at war, but although the resources were very limited, we had a lot of casualties. And I think that we can learn an immense amount from our military colleagues, and I really hope in the future that more hospitals and institutions will seek out the advice of our military colleagues.
Good. With regard to duty to care, I think one of the most difficult issues would be if there were a biological or nuclear terrorist attack, or even a very widespread infectious epidemic that would hit the United States. Those things are so difficult to predict about who's going to respond. And so I would think that under those circumstances, maybe the number of physicians who would step forward and respond might even be less.
I definitely think so, because I think physicians are torn, regarding the duty to care. Because they're torn about taking care of their families and their loved ones, and then taking care of their patients. Because, we did take a different kind of both. But it seems very romantic to say I'm going to stay and die with my patients, but when that decision becomes a reality, it's very difficult to make. And I don't think that we can expect the workforce to be the same as what we would anticipate. I do think they'll give us people, but I do think it's an extremely difficult decision for a physician to make. And I feel that no matter what the disaster is, someone asked me a question about if the AMA lessened their rules or their ethical policies, would that cause a big shortage in healthcare providers and physicians responding to disasters? And what I have found through my experiences during Hurricane Katrina is that those who will stay and serve are going to stay and serve, no matter what the disaster, and those who are not, no matter what the disaster or not. So I think it's a difficult ethical dilemma for physicians, but I think that you will always have those that will respond. But I think there will definitely be a shortage.
One of the things we hope might result from this web seminar, as well as the special issue in Southern Medical Journal next month, is the opportunity for physicians to think about their duty prospectively, and maybe in their mind just say, well, listen, what would I do if this happened, or what would I do? Because if they postpone thinking about that until it actually happens, that may not be the best decision, knee-jerk sort of decision. So hopefully physicians will think about that now in advance and make some sort of commitment or plans, or understand what their response might be.
Just like learning the triage protocols, everything does need to be proactive, as you said, instead of reactive, because that's probably the best position on those.
Now, in addition to some ethical issues, there are some legal issues that surfaced and came to be considered during the Hurricane Katrina. I know that you have talked to state legislators and state medical associations about some of these legal constraints that may need to be fixed to help people feel better about responding. Can you tell us a little bit about some of those legal aspects?
Well, again, as I mentioned earlier, Hurricane Katrina was an unprecedented event. And basically, when the litigation of Holland started after the storm, we realized there was no standard legal care in the disaster for taking care of patients. The main thing that we realized is that healthcare professionals are not legally protected when they respond to a disaster unless they are federal volunteers, military, elected officials. And not all states have passed other acts for volunteers to protect them. So the question was, we're asking people to risk their lives to take care of patients, and then we're holding them responsible for conditions that they didn't create. So what we learned through the process is, number one, that the Good Samaritan statute is not applicable in a disaster if you're working. So it's typically, you stop at the side of the road. It's for gratuitous services. You don't charge. But as you know now, many physicians are employees of the hospital. So if you're an employee of the hospital when you're on disaster duty or you happen to be there when disaster strikes, they consider that not to be gratuitous because you're salaried. And the question is, when does the salary turn on or turn off? So many physicians and nurses and EMTs, medical personnel, thought that they were protected by the Good Samaritan statute to find out they weren't because of those legal authorities thinking that money, passed hands. So we had an amendment to that the Good Samaritan statute is applicable even if you are paid for the services at your salary, and that the terms of simple negligence are removed from the statute because, again, what is the standard of care during a disaster? What is simple negligence? So the Good Samaritan statute, even if you are employed, you are covered. The second one is that some of our colleagues at Lindsay Boggs Hospital, for example, were faced some litigation after patients were not evacuated. The firefighters that called off the evacuation at that hospital during gunfire, there were still some critically ill patients left there. These patients ultimately died, and these physicians who were there trying to save them were sued. So the feeling was that we should also have some civil immunity unless there was willful misconduct or intentional acts. If we are treating and evacuating patients according to disaster triage protocols at the direction of the military. So if the military comes in and say, all of you leave, we're taking over the evacuation, and some of the patients don't do as well, that the civilian physicians are given the civil immunity that is also granted to the military when we're acting under their direction. And the third one is that following the criminal allegations following Hurricane Katrina, many people asked what the medical community had to say about it, and what did the coroner have to say about it. Well, at that time, there was no panel to discuss it. So one of the other laws that we got passed is that the development of a disaster and medical panel where you have a coroner, an expert in disaster medicine, and someone from the state medical society. They look at all of the evidence, and basically what they do is make a judgment on your medical judgment. Did you do the best thing under the circumstances? And then they offer this opinion to the prosecuting authority. So those are three laws that we got passed in our state, in the state of Louisiana, in 2008. And a lot of other states have tried to pass some of these laws, but it's been difficult. They face the same difficulties that we did, that you really have to fight for, because right now, really, there's no state in the union that is protected against this, although I know the state of Indiana does provide defense and indemnification for their physicians if they are sued. So there are many legal issues and many gaps in our legal system because this is relatively new. We all are expected, of course, to do the right thing and to do whatever possible to help our patients, but outcome may not always be the best outcome.
Well, it would be good for every physician who might be interested in being a responder to just see what their state laws are. But it sounds as if the federal government has not stepped forward to mandate protection for physicians responding to disaster yet.
That's correct. It has to be done on the state level. But one way for physicians who are working during disasters, I think would be a good way to approach it is to become a federal volunteer. Because the federal volunteers do have protection against these matters.
How about many states have what's called the Medical Reserve Corps, a group of physician volunteers. Do you know whether they have any special protection, such as working with the Red Cross or things like that?
I'm really not familiar with that. I don't have any knowledge. And I know that many states will do away with the need to be licensed, and they use these physicians as volunteers and they are protected. But I don't really have any first-hand knowledge of what you're speaking of.
In some disasters, they're so bad that the state's physicians may not be able to completely take care of all the casualties or the problems with the patients that occur. So doctors from other states will very likely want to come in and help. Should they know about what protection they might have from that particular state to which they're going to volunteer?
Yeah, and most of those physicians are protected, but I think they need to do their due diligence and find out beforehand what their liability may be.
The difficulty, it seems, we've talked about willingness for physicians to volunteer and respond, and yet if the legal system still has not adequately protected such volunteers, it doesn't seem like it encourages us to help out, with the exception of just simply our altruistic feelings about it.
That's really correct. And I think it's just a difficult situation, I think, for the legal communities who are out there. Their brains are in. And I think, I know when we went to the state legislature, there was some concern that we were giving bad doctors the right to practice bad medicine. But then when they looked at all the facts and the evidence of what happened during Hurricane Katrina to many physicians, because many physicians and nurses faced civil litigation, which was not really known to the public when their patients died. It's just really difficult, I think, to comprehend, but they are learning and they're realizing it. And I think, again, more disasters that happen, unfortunately, in the United States, that our legal colleagues will become more understanding of the challenges that we face. Because it's not medicine as usual. You know, people in the United States, we're the best country in the world and the best healthcare in the world, and they just assume that they'll always have someone there to care for them and they'll always have all the resources to help them. But that's just not the case, as we know, during disasters. So I think we can also help ourselves by educating the public and allowing transparency, maybe have them have some input into these protocols so they know where the limited resources are going, so maybe there will be less lawsuits in the future.
Are there any guidelines or protocols now in how to deal with the acute care patients in a hospital, to where it is anticipated a good number of casualties from a disaster might come, and we might need those acute care beds? Is it just a decision you have to make on every single patient, or are there some general guidelines being developed now?
Well, I think that most crisis care guidelines do discuss the critically ill that are already present in the hospital. The difficult thing about these crisis care guidelines, as I mentioned earlier, is that you have to use the limited resources to save the most number of lives, which means many times that the critically ill patients are given comfort care, whereas the other patients that are more likely to survive are given the limited resources. Every state was required to have a uniform crisis care guideline. I know the state of New York has concluded theirs, and that's so that everybody agrees to follow the same protocols. And these are well thought out and well planned protocols. I think everyone has to realize, if possible, the best way to prevent these ethical decisions and dilemmas is, as I said, to evacuate those patients in advance, if you know, and we're fortunate with hurricanes, but we typically know that. And the best way to avoid it is to really know your disaster protocol inside and out, to have drills, not only medical but ethical drills, so that when the time comes, you are really prepared to take care of the influx of patients and to deal with the critically ill patients that are already there. Because again, if you are standing there in the midst of it without knowing this, it's going to be extremely difficult to follow those protocols and to do what needs to be done to save the most number of lives. So I think knowing the protocols and really being prepared, doing drills, and being realistic about what may happen and not put your head in the sand are the best ways to deal with that. But there's no problem per se in each state of handling those critically ill patients.
I think for physicians who are interested in becoming more prepared in the event of a disaster, the National Disaster Life Support Foundation has, with the AMA, developed some excellent training courses. I was just certified in advanced disaster life support at the University of Mississippi, an adjacent state who, like Louisiana, has had its share of flooding and hurricanes and tornadoes and so forth. So I would encourage physicians to look into the basic and advanced disaster life support courses, particularly if you live in an area where disasters are likely to occur, which, looking back over the last 10 years, is in most of the states of the United States. There was just a hurricane or a earthquake off the coast of California recently. The southeast and the south always have problems with disasters. Midwest, flooding, tornadoes. You're right about hurricanes giving you some warning. And I guess it was not only the hurricane itself that caused you trouble, but the breaking of the levee that led to the flooding here in New Orleans.
And that's what made our situation more difficult, let's just say, to Hurricane Sandy. With the breach of the levee system, there was massive flooding, and we were completely isolated. It's not as though someone could drive in and take our patients out. So we were completely isolated for a long period of time. That's that our communication systems throughout the entire city were down. And if you didn't have a redundancy communication system, you had none. And it took the federal government a very long time to respond. We essentially lost all of our city infrastructure and our hospital infrastructure. And there was, I think, gross unpreparedness at every level of government, city, state, and federal. That made our situation a little different.
Some of the difficulties that occur possibly are related to the geography of a particular area. And flooding is always a problem because it's difficult to get to in individuals. And I gather the hospital you were in, you would have to have a boat come, an ambulance boat to come and evacuate your patients.
Well, that's exactly what happened. Thank heavens volunteers from other parts of Louisiana came in their airboat, and they appeared on that Wednesday after the storm, and they actually did save many, many, many of their patients and other people, because we have people from the community, family members, non-essential personnel. The hospital had almost 2,000 people. So they did have the boats that ferried a lot of patients out. The problem is those people who were stretcher bound and critically ill, we had to wait for helicopters to come, and there was a delay in that. So when you are planning your hospital, disaster plan, I think it's very important to know, how are you going to transport patients? Is it by boat? Is it by land? Is it by air? Make sure that you have agreements with those different entities, and if you have to, you should really hire your own the way that a lot of industry does. I also think it's very important to have a central location. What happened with us, we evacuated our patients we knew where some of them were going, if they went to an acute care facility, but others we didn't know. So if you have some type of an arrangement to switch a facility in advance, I also think that is extremely important. Many of our patients just want to drop site waiting for rescue by ambulance or helicopter.
So is it just the responsibility of the hospital administration to develop the disaster plan, or is there a role for physicians in that plan?
Absolutely not. There is a great need for physicians to be proactive in disaster planning. And it is a problem because most physicians say they are too busy to attend yet another meeting. We have so many pressures on us nowadays, particularly, and it is difficult with stretched very thin. But everyone has to be proactive. You cannot depend upon anybody else to tell you the disaster plan when the time strikes because they may not know it. And let's be honest, we don't know what we're going to be when disaster comes. So I think the physicians absolutely have to take a very proactive role in understanding what their role is and what the disaster plans are. Absolutely. And I think that we could do a better job of that.
I might add to that for any disaster plan, it's important to have an ethicist as part of the planning problem. I was on our university hospital's disaster response team as an ethicist, not as a surgeon, and it really became important looking at how do we respond to given situations, because almost everything in medicine has an ethical aspect to it, and certainly disasters are.
I think that is a very important point, and I have been a proponent of that very early on because when you're dealing with, crisis standards of care and lack of resources, almost every decision you make is an ethical decision because it's so different from the typical tenets of ethics that we practice every day. In addition to having ethicists, I really think it's important to have a chaplain or some psychological, spiritual person on the team and also an attorney. I think all those things have to be looked at because I think you really need the input of all those people into that.
Your last statement leads me, I think, to our last topic, and that is the personal toll, the emotional toll and stress that serving in a disaster as a physician takes on a physician must be very great. I know of nobody who has experienced any greater stress than you have about your own experiences. And would you care to speak a little bit about the emotional and personal toll that disasters might take on physicians?
Well, as you said before, when we're taking care of patients from disasters, we follow these disaster medicine protocols. And it's really difficult for any physician, I think, in the United States of America, to face the reality that they may not be able to care for all the patients. And that really did lead to severe depression among many physicians. PTSD, severe depression, and really the terrible feelings of isolation that no one else can understand how you feel were really pervasive among the nurses and physicians that care for patients during Hurricane Katrina. Not only are you facing that emotional toll of being with patients in the hospital for a prolonged period of time and you can do very little for them, but many physicians, depending on what the disaster is, may have other stresses such as losing all their financial support, their practices, their homes, family members. So you're dealt with not only taking care of patients during disaster and the aftermath, you're expected to continue to do so despite all of our other personal losses. And during that time is usually when you don't have the support system because you send your family and your children away to the state. I think all of that is just extremely difficult and emotionally challenging for many people. As a matter of fact, I know many nurses on Hurricane Katrina have yet to return to work, and they never will because of the trauma, the personal trauma that they suffered. And I think ways to really counteract this, that on the disaster team, I really think there should be someone to provide psychological support, psychiatrists or sociologists, or psychologists, because during the disaster itself, you're watching people die, there's stress, and not everybody can handle that well, and it helps you to maintain your resiliency. And then following every disaster, no matter how insignificant you think it may be, I think everybody needs some type of debriefing and psychological counseling. And as physicians, I think many of us don't want to admit that we need any type of help, but really a lot of caregivers in the situation do need a lot of care. And I think it's important to realize that it's necessary and that you're not alone. And it may take months or it may take years for you to get over this trauma that you've experienced.
Well, it's a difficult situation, but Dr. Poe, I want to thank you for taking the time to talk to us about your experiences. I hope that physicians who see this seminar will think very closely about how they might respond to a disaster. Some of the issues that they may face have been brought out by you very nicely today, and I thank you for taking the time to do that.
Thank you, Dr. Holt. Hopefully this will help.
And I also would like to recommend to the physicians who are seeing this to look at the special issue in Southern Medical Journal on disaster medicine and physician preparedness. Thank you very much for tuning in, and we look forward to the next seminar on ethics in clinical medicine.
Thank you.
This educational content was brought to you by the Southern Medical Association, a nonprofit, non-political physician membership organization with a primary purpose to providing quality continuing medical education for physicians and healthcare professionals. For additional educational content, to join, make a donation, or for more information, visit us on the web at sma.org or call 800-423-4992. Thank you.